Is this a great conference or what? You know, Dr. McLean, just year in and year out, pounds out this one of the best meetings in the country, and just humbly goes about his way. So I think, David, you deserve a round of applause. So historically, the highlight of the meeting, at least for me, has been the Thieves market, and we solicit cases from across the country and across the world to be presented at this meeting, and at the end of it, you, the audience, gets to decide what you think is the best case, and the winner, they get a Lexus this year, is it? Okay. So we've had cases submitted from Japan and from Dubai and from India and all across the world, and what we will share with you today are four of what I thought were the best. And to lead us off, we have Dr. Luck Wynn from the University of Texas at San Antonio is going to present the first case.
Good afternoon. I'd like to present a case today on fingers and joints. Our patient's a 52-year-old man who presented with a 6-week history of painful fingers. He was seen 4 weeks ago, and he was diagnosed with Raynaud's. Patient was placed on nifedipine with no significant relief, and now he shows up 6 weeks after onset of symptoms with blackening of his fingertips. Review systems was notable for a decreased appetite and a 5-pound weight loss since the onset of symptoms, but otherwise unremarkable. He has a past medical history of Hep C, untreated, no recent invasive procedures, no surgeries. His mom had diabetes, but no family history of autoimmune disease or thrombotic disease. He had a 30-pack-year history of smoking, but he's quit over 10 years ago. He drinks 1 to 2 beers every night, and he's been smoking marijuana since he was a teenager. For the last 10 years, he's been smoking on an almost daily basis, and since the onset of his painful fingers, he's been smoking more, up to 10 joints a day to try to relieve the pain. He works as a construction worker. He does a lot of work with wet concrete, but doesn't work with jackhammers or anything like that. And he stopped working 6 weeks ago when his fingers became painful. His only medication is nifedipine. On physical exam, he's afebrile, vitals are unremarkable, he's average height, average weight, he looks pretty fit, looks pretty healthy, non-toxic appearing. On examination of his hands, his fingertips are cool. There's purple discoloration. The affected areas are very tender. There's eschar formation, mostly beyond the DIPs. Sparing the thumbs is noted. There's decreased pulsation over the ulnar arteries, and an Allen's test is consistent with ulnar artery compromise. The remainder of his exam was pretty unremarkable. No other skin lesions were noted, and no evidence of joint inflammation. These are his corresponding hand films. So MCPs, PIPs, DIPs, and carpal joints were pretty unremarkable. He had an extensive laboratory evaluation. His CBC was completely normal. His platelets were in the 450s. He had a normal creatinine, normal LFTs. His UA was negative for protein, negative for blood. He had a SED rate of 31. His Hep C antibody was positive, but the Hep C viral load was negative. His urine drug screen was positive for marijuana, but negative for everything else. His serologic examination was completely unremarkable. We did an ANA, which was negative. We did a Smith, RNP, SSA, and SSB, which were all negative. Scleroderma antibodies, including SCL70 and centromere, were negative as well. We did an APS workup with lupus anticoagulant, beta-2 glycoprotein profile, and anticardiolipin, which were unrevealing. His hypercoagulable workup consisted of a factor V Leiden, which was wild type, prothrombin gene was wild type, and homocysteine levels were normal. His ANCAs were negative, cryos were negative ×3, and his complements were normal. They were not low. This is his angiogram.